questions and kind of see what the common themes are. We'll pluck out one or two or three that we find are common amongst the conversation. We'll open up for Q&A if there's anybody who wants to ask a question, and then we'll kind of wrap it up. Sounds good? Awesome. So with that, I'd like to start by introducing, is it still doctor? It's still doctor, right? Dr. Christina Hoopen. She's the professor for ethics and theory of medicine at the University of Cologne. There, she is the executive director of the Cologne Center for Ethics, Rights, Economics, and Social Sciences of Health. She's a member of the International Bioethics Committee of UNESCO and coordinating a report on big data and health that you guys are launching out pretty soon. She's the former chair of the German Ethics Council and president of the 11th Global Summit of the National Ethics Committee. In April this year, she was elected chair of the European Group on Ethics in Science and New Technologies, advising the European Commission. So thank you for joining us. After that, we have Jay, and I'm sorry if I say it wrong. I'm going to try to say it. Kumarnani, am I right? Kumarnani? No? How do you?
Kumarnani.
Kumarnani. Okay. Say it faster. Got it. Is the founder and chair of the Human Diagnostics Project, which is a worldwide effort to map any human health problem to its possible diagnosis. And prior to that, he advised leadership at some of the world's prominent organizations while working at McKinsey & Company and Bain & Company. Thank you for joining us. And then after that, we have Barry Ressler. Did I say it right? All right. Who is the chairman and CEO of the International Space and Medicine Consortium, which focuses on enhancing the knowledge of space medicine to develop diagnostic and therapeutic protocols using artificial intelligence. Prior to that, he has served as CEO of public and private corporations in the medical diagnostics, defense, energy, and electronic space. He holds 7 patents in the field of monochromatic UV sterilization of industrial fluids, blood products, injectables, and healthcare packaged products, as well as drug delivery through IVs. Fantastic. Thank you for joining us. And last but certainly not least, Dr. Abha Saxena leads the she leads the work of the Global Health Ethics Unit at the World Health Organization. Internally, she heads the secretariats of the Research Ethics Review Committee, the Public Health Ethics Consultative Group, and the Global Summit of National Bioethics Advisory Bodies, as well as the Ethics Resource Center. Her team is the focal point for the examination of ethical issues raised by current agendas and activities throughout the World Health Organization. Trained as an anesthesiologist, Abha was the professor of anesthesiology at the All India Institute of Medical Science, New Delhi, until you joined the World Health Organization in 2001. So I know we've heard, thank you for joining us, by the way. I know we've heard a lot today about ethics and AI and who's going to police AI, and really we want to focus this panel on AI for the use of health, in particular making healthy citizens. So with that, I really want to ask a question to each of the panelists, and I'll give you guys each a few minutes to talk about it. And the reason behind the question is more the frame at which you see this discussion, right? So why AI in healthcare? Why is it important? And what's your viewpoint on it and challenges and things you see? So 5 minutes each, just kind of the framing of which you kind of came into this discussion. We'll start.
Okay, thank you very much, Jay. Mo. So my viewpoint is the one from ethics. And one guy already mentioned this morning that we have not only a responsibility when we use data, but also a responsibility if we not use data. And so I ask myself, where are data relevant to become healthier citizens? So when do citizens get healthier? I think there are 3 points. The first point is half of the population is not health literate enough. So health literacy of persons, their own contribution to their health is important. And worldwide surveys show that half of the populations have not enough health literacy to search, to access, to understand, to assess, and to apply health information. Second, the environment can contribute to healthier citizens, first by promoting their health literacy, and secondly by providing healthy living conditions. There are hundreds of aspects. And third, we have 90% of data in healthcare that are not used to improve healthcare systems and healthcare. This message is alarming, but
It's a data problem. Hello? Hello? No, we're all down.
I just continue this way, okay? Yeah.
Can everybody hear her okay?
So, and what is the solution? The solution, according to my viewpoint, is that we build up, establish learning healthcare systems by using artificial intelligence, by integrating data not only from healthcare, but also from the behavior of people in everyday life, because then we can avoid prescribing drugs that are not effective, that might be effective in clinical trials, but that are not effective in everyday life under different conditions. We can avoid more than 1 million deaths worldwide due to medical errors. We can avoid interactions between drugs that are not compatible, but it is not suitable to have randomized clinical trials under conditions where people are 80 or 85 years and older and they take multiple drugs. So we don't get to know what happens in everyday life in healthcare and outside of healthcare when we do not take all the data we have already and make them fruitful for research, for building hypotheses, for new clinical trials, but also for finding correlations, for finding relationships between behavior, drug consumption, medical intervention, diagnosis, having therapy afterwards, and have results that we can feed back to the healthcare system. Once, to inform people, to make them more health literate, and second, to improve health care, and third, to improve healthcare processes. So the institutional setup of healthcare systems, sometimes they're quite sectorial. There are hospitals, there's the ambulant, the general practice, and they're not combined. So these processes of healthcare are not very integrated. So my dream would be that artificial intelligence is actually used to establish learning healthcare systems, which are, by the way, culturally sensitive. Yeah? Because you do it in this area, and patients and citizens can participate by giving their data, by collecting their data, by using their smartphones to contribute to electronic health records that are integrated and that are compatible with research purposes.
Great, thank you. So it's not for discussion yet, so your turn, and I want everybody to kind of give their
Just
framing.
to clarify, I thought we were going to wait on proposals, and this was...
This is not a proposal. This is the
okay,
question,
gotcha.
just answering the
Okay.
question in any way
Great.
you want to answer it. There's
Fantastic.
nothing around proposals, yeah.
Well, thanks. I think you guys probably don't know of our organization, so I actually provided some additional context to Mo, but I guess it wasn't
Please.
updated in time. So the Human Diagnosis Project is a worldwide effort to map the best steps to help any patient. It already involves physicians from about 70 countries, 500 medical institutions, and 40 specialties who have contributed hundreds of thousands of cases to the system to essentially build a human interpretable and machine processable data structure that can ultimately be accessed by any human, machine, or organization to improve the cost of care, effectiveness of care, and access to care globally. So as I kind of present some of the ideas that we're thinking about, I think it's helpful to have that context, given that comparatively we're a less known organization. So just to kind of get started, I think there's two things that we care about deep. Is this not working?
It's working.
So there's two things we care about deeply. So I think one is using AI to serve the unserved. That's kind of how we think about it. You know, typically when we're thinking about AI broadly, we're thinking about how to make existing processes, frameworks, or people more effective, or potentially automate or replace jobs. I think we think about it in terms of where can AI play a role in helping people who have no other option. And that's essentially one of the primary focuses of our project. We think the application of AI is so important to healthcare because it is the most fundamental need. It's the thing that people care about the most. The way we kind of describe it is the essential question of human health and well-being is when you or someone you love isn't well, what should be done? And that's really the question that the project that we're building seeks to answer. With respect to how we think there may be an opportunity to do that, healthcare is tremendously complex because of the number of types of information that all have to be integrated to come to correct answers at different scales and dependencies. So you have everything from genetic data to symptoms to lab tests to social history to a wide array of different factors which ultimately impact patients. And because of that, we don't see pure AI in the true healthcare sense being the solution, at least for the next decade, if not longer. We think of the idea of what we call integrated intelligence. So this is combining the insight of multiple humans, machines, and organizations to produce a complex system that ultimately produces significantly better results for all stakeholders. As one simple example, in our own system, we found that the average physician dramatically still outperforms machine-based systems like symptom checkers and clinical decision support systems, which was research we published with Harvard Medical School in JAMA, the Journal of the American Medical Association. Interestingly, though, the next study we're publishing is actually showing that collective human and machine intelligence can outperform 98% of physicians on broad-scale generalized diagnosis. So machine-based classifiers work really well for narrow intelligence problems, like solving pathology and radiology in very specific contexts. They do not work on very complex clinical decisions with multiple scales of different data. And so we believe the primary challenges that need to be addressed with systems built around AI to solve healthcare today are solutions that allow the integration of human and machine intelligence.
Thank you very much. Appreciate it. Larry?
My company, the Space Medicine Consortium, is involved in evaluating health problems for astronauts in the future of colonization. But all of the protocols and all of the diagnostics and therapeutics that we're using is based on protocols that we have developed. We developed prior to the founding of the company, and we're now integrating the companies where they were developed into the space medicine protocol. One of the areas that is very important, an area that's very important to us is in the inactivation of virus and bacteria and thermal resistant spores. And we have had a very long, successful period on Earth. The reason I bring that up is that in the space environment, we are now facing mutated organisms, those where the DNA and nucleic acid has been affected by radiation, and through shock waves where there's water content, OH radicals. And being at a remote distance, we are now depending on artificial intelligence as we gather our data and dose response in an orbiting CubeSat. Now, taking that into consideration, we are very sensitive to areas of Earth where there isn't medical care, where there isn't hospitals, available physicians, and information that AI can report, whether it's just an evaluation of the content of water, whether it's the speciation or the evaluation of an outbreak that may not be an epidemic at this time, but can share information that may be of value to a protocol that could catch it early and inactivate it. So we believe that AI will play a very important role. We are also involved with AI in education, but I was very pleased to hear that the education of humanity for medicine that was brought up earlier is extremely important. And we have seen issues of pharmaceuticals being used by elderly people without any understanding of what the interaction is of the multiplicity of those pharmaceuticals. And to do that kind of analysis, that education is very critical. But we are also working on STEM and STEAM education using robotics for the educations in various countries, and we've been evaluating the responses of children in Switzerland, in Italy, Brazil, and the United States, and expanding the program. So artificial intelligence is a very critical part of our success in addressing many of the problems that I've just mentioned. I'm very pleased to have been invited to the conference because I've heard expert comments on the current state of artificial intelligence, challenges that we may not have anticipated because we're basing our artificial intelligence on work we have done with dynamic modeling and simulation and doing with human effort an analysis that can be done by artificial intelligence and transferring that to an AI device, and also to have machine learning that might be able to provide information when they encounter an issue that isn't a match for what is in the database or in the machine learning that we have achieved. And that is a very, very important indicator, and it would happen a lot faster than if we were doing this on a laboratory basis, if it was participation between human and the artificial intelligence.
Perfect. Thank you. Doctor?
Hi, good afternoon, and thank you.
Of course.
So the question you asked was, what does AI in healthcare mean to you?
Mm-hmm.
And given the fact that I'm working with the World Health Organization, for me, the extreme shortage of healthcare workers around the world means that I'm really interested in the various ways artificial intelligence can be used to support public health and health systems, especially in developing countries and hard-to-reach areas. As you heard from my introduction, my area of work is actually global health ethics. But given that many of the sessions in this conference have already covered ethical issues quite comprehensively, what I would like to touch upon are two problems that are relevant to the WHO. The first is the question of that I would like to pose to the group or to the AI industry actually is, how can the AI industry ensure that the algorithms and outputs are inclusive and take into account the data and variables from developing countries, especially the rural populations and hard-to-reach populations, so that the solutions provided by AI are relevant to them. And in the same vein, how can the AI industry ensure acceptability of this technology, not only by the rural illiterate population in hard-to-reach areas, for example, in Africa or Asia, but also by the healthcare physicians who work in these areas. This means that a lot more work is required on the ground to ensure that these technologies are introduced in a culturally acceptable manner, and the traditional role of healthcare workers is neither undermined nor made redundant. So perhaps this is not an AI work, but I think this is a work that AI industry needs to do before AI can be accepted. My second problem that I would like to, that I'm interested in, is in the area of new drug and vaccine development. As some of you or most of you may know, that drug development, vaccine development is a very slow and expensive process. And often it's quite messy. It's required to do clinical trials in human beings over long periods of time. Various phases of clinical trials are required. Sometimes people die, and then sometimes it doesn't go through. I feel that AI has the potential to cut both the cost and the time. There are many emerging diseases with epidemic potential, and we have at WHO already identified at least a dozen such diseases for where neither the vaccines exist nor therapeutics. And these are diseases because of globalization and because of changing epidemiologies are likely to become prevalent very soon. For example, we saw the Zika virus outbreak, which nobody had anticipated. And developing drugs and vaccines for this will take time, and we don't have the time. So I think what I want to know is how can AI help us, not only to dramatically identify new molecules, but also to decrease the drug and vaccine development time for me, there are others, but I've just identified 2 questions.
I think that the list is endless, and I'm happy that we have a pretty diverse panel. So moving forward on the next few questions I'm going to ask, you guys, I definitely want participation from each one of you, and I'll kind of moderate as we go through them. But one thing that's very interesting to me, and definitely sitting through the conference so far, is AI seems to be something we talk about in this very arbitrary fashion. And what I mean by that is that we see a robot doing something, and we go, what is that? Well, that's AI. But that's not really an answer, right? So to me, you know, AI can't just solve everything. It has a place and position for what it does. So where do AI and humans work together? And I'm asking this in a broad question. I know everybody will have different angles at it. But when we say AI coming into the picture, how do those 2 areas merge, right? Because I think ultimately, to a point you made, Jay, which is the combination of the 2 is very powerful, right? So how do humans and AIs work together in the context of just healthcare, right? What are some of the things you see there? What would AI be doing? What would the human be doing, right? I think one of my favorite videos that we saw was the robot that would ask for help for coffee, and it doesn't know what coffee is, and just asks somebody to put it in. And one day we could argue a robot will be putting the coffee in. I don't know, but it's an interesting discussion around, especially in health, where I don't think anybody will disagree. A touch of a human is very valuable in healthcare. So how do we combine those 2? I don't know if anybody wants to take it first. Let's jump in. Doesn't have to go down in order. And I'd love for you guys to comment along, and I'll help moderate through that. So.
I think there are 3 starting points.
Okay.
One is the data. So having all the data and interpreting them and pointing to some correlations on the long run, having surveys and so on, and having some hypotheses coming out of them. But you need the humans who know about the surrounding or the prerequisites, the surrounding contextual conditions, the living conditions and so on, to interpret them finally. Because there are so many examples where data interpretation just by machines lead to very weird policies, yeah, because you don't have the interpretational background. Second is just in doing something, doing surgery together with robots or other systems, having telemedical applications and so on. And the third one is application of something, of decision support systems, of integrating data and doing a good diagnosis, merging it with the current evidence from scientific literature in large databases no individual can really know and read, but then referring to it and integrating it really in evidence-based medicine, what means integrating experience and individual experience and intuition of humans as well, not only seeing data, but seeing the concrete individual in front of you and giving advice for his living.
So more like assisted intelligence more than artificial intelligence. Yeah, right.
Yeah, just to continue on that theme, I think there's different ways to look at intelligence as a whole, right? So there's the idea of augmented intelligence, so expanding the capability of a human or other agent using machine intelligence. There's the idea of pure AI, which is having an AI answer a question better than a human potentially, for example, with radiology images. And then there's the idea that I kind of mentioned earlier, which is this idea of integrated intelligence. How do you use humans and machines together in a system that weights their intelligence appropriately for a given problem? And so I think there's a couple pieces I'd like to kind of discuss with respect to how we think about that problem generally, and kind of the specific case of how we're kind of implementing some of it. I won't go into as much here. So the first is that one of the biggest problems in AI today is the lack of labeled training data to accomplish certain goals. So basically what we've done for the most part with AI to date is, hey, we've captured all of this data for some purpose. That probably wasn't the purpose of building an AI, and we're trying to now backfit or interpret that data to come up with some conclusions or some interesting insights, as opposed to kind of thinking from first principles, how would we capture the data that is necessary to actually solve the problem that we're aiming to solve? So I think one is actually building interfaces that capture, structure, encode labeled training data that allows us to actually solve the problems that we set out to solve. So I think that's part one for me. I think part two is essentially around this idea of how do you weight the knowledge of different agents in an integrated intelligence? So if you have multiple physicians pontificating on a case, for example, and then you have multiple machine agents pontificating on a case, which could be a bot, it could be a distributed instance of a piece of software, it could be any number of things. How do you then decide which of those has knowledge that is relevant to that problem? And so this is actually a broader idea in essentially kind of, I guess distributed consensus theory, which is essentially around the idea of an epistocracy. How do you weight different people's perspectives or different agents' perspectives accordingly? And what we've seen, at least, is that for the foreseeable future, human-in-the-loop machine intelligence is an absolute must. And so your earlier point about decision support is the right one, because for the very foreseeable future, these systems are not going to be at a high enough fidelity and robustness for the sheer edge cases that can emerge for the complexity of cases as they actually manifest in real life. And then the third one, and the final one I'll mention right now, is the idea of creating ontologies which can actually allow the seamless communication between different types of agents in such an integrated intelligence. So one example is basically how ontologies are used for different languages around the world. So if you're building a system which could potentially work in some language, you want it to potentially be able to work in all languages for all different types of humans. Now the second that you actually need to do is to deal with people who have technical expertise versus people who only understand plain language. So that's another application of ontologies. So imagine you're building a system with training data understood by clinicians, but is not understood by community health workers. That is another problem that ontologies can help solve in terms of capturing the right types of data and information. And then the third problem that can be solved with ontologies is human and machine communication. So basically, as you probably heard from the plenary discussions, one of the biggest problems today is that AI is not human interpretable and auditable in a way that it needs to be. And in the same way, as I pointed out to you earlier, the labeled training data that we're capturing is often not captured with the express intent of being machine processable. We can actually solve those problems with ontologies. And so those are kind of three examples of ways that we can enable human and machine collaboration.
So those are interesting things, and they bring up to mind just a few comments, and I know I saw Abha has a few comments as well. There's almost a, if we were all here as humans presented with a somebody with their arm cut off, right, we would conclude certain things rather quickly. Whereas an AI would need input, to your point, and input in a way that makes sense, that's labeled properly for it to give a proper answer. Which I find interesting and also fascinating at the same time. Because when we talk about how an AI can be auditable, I would argue to say, how do we audit humans today? And it's a very arbitrary way of doing it, right? We have other humans audit humans, right? I mean, this is a judiciary system, essentially, or a set of laws we all agree on. And then it raises another question, of course, of standards, right? Does that mean in order for AI to actually become something that everybody participates in, that we all have to have a common standard? I'm not necessarily looking for complete feedback on it. I just think those are interesting observations that come up through discussions. And definitely, I think today the question of AI raises a lot more questions over time, right?
Yeah, just a real quick reaction, and then I'll pass it to the other panelists, which is that is the concept that I mentioned of an epistocracy. So you need a way of objectively measuring an agent's knowledge about things which are true, right? So for example, the way we do that in Human DX today is when we're comparing clinicians' intelligence to one another, we actually have them solve a reference set of training cases which we know are correct based on what actually happened to the patient. And by using that as an index to essentially create their clinical quotient in the system, we can then begin to index who knows what about what, so to speak. And I think that's, you pointed out, that's a tremendously important part of this.
So Abha, I know you had a comment, and then we'll come back, yes. Can we turn on, up the mics a little bit, unless yours is not on?
put it closer to your face. Yeah.
That's the closest she can go, short of putting it inside her mouth.
I'd have to eat it. No, so just reacting to something you said, and that was different people making the, different groups of people making the diagnosis and then collecting that, using the collective information. But in medicine, a lot of the diagnosis is based on context as well. And so you could actually, if the people who have contributed to your AI were based in New York or in Australia or somewhere else, and this AI was used in either in Africa or let's say in Indonesia, the output may be completely different just because the context is so different. And so I think when we develop systems for diagnosing diseases and conditions, one would need to keep that in mind to say, where was it developed and where is it going to be used? I also think that because medicine is such an imperfect science, so even when a physician makes a diagnosis sees a patient, makes a diagnosis, it's not A plus B is equal to C. There's A and B and C, and putting A, B, and C together, the chances that this person has X is this and Y, and then because he has a family history, I will not choose X, I will choose Y. So it's a very complex algorithms that physicians use, and that's why I think that AI alone is not likely to be sufficient to provide the diagnosis or to provide health care. There would need to be a human interface, at least in the near future. But I also want to say two other things in relation to AI and human and machine interface. The things that are currently important in the healthcare system are care and compassion at the physician end and trust at the patient end. And I think these are important values. There are other values as well, but to me these are they just jump out. And a machine itself or AI itself, probably in the far future we would be able to integrate those sort of values as well, but for the time being I think we cannot trade off those values in the healthcare system.
Well, the question about human and artificial intelligence interaction, can they hear?
I don't think so. Can you guys hear? Can you put it a little closer?
That better?
Yeah.
Much better.
We create algorithms that are really the baseline for how the artificial intelligence for a particular application or an application-specific issue will function. We have hopes that over time, as problems are identified with the artificial intelligence, that we may see some recommended, suggested, or obvious changes to the algorithm, which we might find if we were operating independent of artificial intelligence or with artificial intelligence. But I see the human and AI interaction being very, very dominant. I don't see that changing at all. And I also see that we would be evaluating the performance of AI as it gets into extreme circumstances and not the baseline. Another area that I didn't mention before is antimicrobial resistance, which is a very significant problem globally and different in different parts of the world. And I believe that we could apply various algorithms or AI concepts that would be very helpful as we are doing in parallel in the laboratory with humans. So I think this is important. The other point I wanted to mention was robotic surgery. It's been around now for close to 10 years. I've seen a wide range of performance, but the surgeon-dominant opinion is that they would like to have an interrelationship with the patient and almost a touch and feel as more advantageous than robotics. And of course, that's been challenged by a number of lawsuits, which I think have been moving aside now as things get better, and I think that has to do with training. But it's very possible that that training could have artificial intelligence to work with the surgeon that might improve that practice. So we see artificial intelligence as a very significant part of healthcare.
So one thing I like that, Jay, you mentioned about artificial intelligence is the differences of artificial intelligence. So we group everything into AI, but really there's segments of what AI is, right? From augmented to assisted to is it truly artificial? And I'll ask one more question in a direction that we'll start kind of narrowing it down. One of the most interesting things to me is that, especially when we talk about the context of developing worlds, while we see AI taking off and we're definitely using it for, and I'll use the context of assisted intelligence in my personal opinion, only because I think we're using AI to do tasks that are repetitive to a human or take time for a human or could have, that should be, it's kind of, we use AI to answer the question, what's 1 + 1? Because we know it'll always give us 2, where a human might make an error, right? So things like looking at pathology scans, radiology, so on, at least with a high degree of confidence. But now, what about the other end of that? So we see people using very low-cost tools, if we flip that switch completely around. We've seen people come up with ways to separate blood to be able to do that in the field, just using a carton and a string. Is there a play for AI everywhere? Or kind of, where do you draw the line? Where does this low cost come in? And again, I'm bringing this in context of when you start thinking about how do we deploy it everywhere. Even if we think about developed countries, you can't deploy it everywhere because cost prohibitive is going to be a problem, right? So it's a very, open-ended question in the sense I want a conversation around really, we tend to, as humanity, we tend to put our hopes on something, and I'm wondering how does that apply when we start talking about it going global, right? Very open-ended question.
What I always wonder, but during all these days, is that we are talking about an impact on millions of people.
Exactly.
The whole world will change. Everything will be different in some years and at least in some decades. But in the end, the one single human being counts, and his or her quality of life, even in healthcare. Yeah, so artificial intelligence, at least on the databases, but you already mentioned that there are several possibilities to apply it, is about probabilities. And now I see, well, if I give you this drug, if I prescribe this drug, there's a possibility that you live 2 years longer, let's say 60%. But that does not say something about you personally. And your quality of life, and your preferences, if you prefer this drug to another drug or this drug to surgery, and so on. So these very basic things will stay, yeah, and they will have to be solved. And quality of life, and that's what I wanted to add to objective approaches and to the truth, yeah, to really have access to what is true. Truth from a philosophical perspective is a quite ambivalent and ambiguous notion. Quality of life is a subjective notion. Yeah? How I want to live and what I appreciate as a wonderful life can be something completely different to what someone else counts as a valuable life. So we have to take this individual view into account and to integrate them in the AI systems from the beginning, like someone proposed to integrate the human rights approach as values in AI systems. And that's why I think that patient-reported outcomes, citizen participation, participatory approaches to even already to develop AI applications is very important, because their perspective can differ completely to the professional perspective and the technical perspective and so on.
I'm a bit of a romantic, so anything where it's simple and easy, that to me is huge. I mean, this is where AI changes the experience, right? When it knows something about you that delights you, right? When you do something and you're like, oh, like I feel good, right? That's what we try to achieve anyway. Yeah, sorry, Jay.
Yeah, absolutely. First, I want to agree with the other panelists on a couple fronts. So one was the importance of context. I think I 100% agree with that. And that's part of the reason, at least in our own application, why we really want people from all over the world contributing to such system, and why we already have people from 70 plus countries. That being said, I think the power of AI in an integrated intelligence of humans and machines is collapsing the solution space. So basically, if we look at the primary drivers or parameters which determine the nature of given problems and how to diagnose them or treat them or manage them, the first two, which are the most relevant, are actually not even where you're based. They're kind of your gender and your age. And then, of course, factors like your obesity, your body mass index, things like where you're located, all of those parameters do matter. The power of using AI with humans is allowing humans to narrow the solution space faster, and to potentially think about what could or couldn't be right. And then the value of humans to AI, on the other hand, is understanding when there may be situations which are ambiguous and aren't clear-cut and don't have objective truth. And in those situations, allowing humans to basically close the loop with such a system to say, hey, this may or may not be the right answer. And I do agree with the general point that truth is a very tricky epistemological question. That being said, I do think there are things which are more true than other things, and truth is an approximation that moves towards some extremely high likelihood probability. And
Sounds
so
like
I think
that's a different conference. If we're going to talk about truth, that's
yeah,
whole.
but I do think it's relevant because I think
Oh, I totally.
because I think we want to use such systems, software systems, data, AI, to help us come to better approximations of reality.
Right.
And we can agree that we're probably sitting in this room right now. I mean, obviously, get existential about it. But the point is, there are things that seem to be more true than other things. Now, the last piece I'll mention is actually kind of my take on your question, which is, in the future, we're going to have a world where everything is connected and programmable, right? First, it'll be things like the Internet of Things. But in the future beyond that, literally, we will have programmable matter, right? We will actually be able to manifest things in physical reality as we choose based on data, information, and artificial intelligence. That being said, we shouldn't wait for that day to actually begin using AI to make impacts and by using it to improve human health and well-being where we can even today. So one of the big limitations, as I mentioned earlier, was we don't have the data to solve many of the problems in cultural contexts and locations where it's difficult to get such data, which is a point we discussed actually at length yesterday. The biggest problem is actually getting the data for those given communities and context. And so one idea I'll quickly leave you with, which I think is quite
I hope you're not leaving after the idea, but
No, I'm not. But one idea I think that's really helpful is, how do we get data in context with unreliable internet access where you can't actually get people online and you actually need them to write to such a system? Well, you really have to solve a couple major problems. So one of those is you actually need to be able to allow people to coordinate without internet access. So things like mesh networking, which allows Bluetooth and other protocols to allow data exchange between individuals in those contexts. And then I think another one related to that is actually being able to capture or to actually compute in a distributed way where you don't have internet access. And that's an area that's emerging right now called edge computing. Yeah. So I think both of those are potentially interesting areas.
Well, we can either give everybody in the world an iPhone or do what Google does and launch a balloon in the air for internet. For the record, my body's here, but I'm not present. Just so we so I want to begin focusing the panel a little bit, and actually one more comment, then I want to start focusing the panel a bit. And I'm hearing a recurring theme of a few things, so I'll mention those, and then I want to open up for a little bit of Q&A, and then we'll kind of refine it, and we'll wrap it up. But one last comment on that conversation.
So I just wanted to say that you asked about AI, and I think it's extremely important that AI will be used in more and more parts of the world. But we have to understand that the way that we have seen AI being successful in medicine so far is because in situations where we have electronic medical records, where we have everyone has access to smartphones, perhaps many people have the Internet of Things already working in their homes, and therefore there is a seamless sort of a circuit being formed. What I would like to see actually being successful is AI being used in situations where we don't have that sort of connectivity and that sort of internet access, at least on a more regular basis. So it could be there, it may not be there. And to see how we can actually use AI in these situations, because otherwise we are leaving half of the world behind. I mean, this inequity is going to rise hugely, and the haves will have more, and the have-nots will have less, much less. So I feel like we really need to make that effort to get the 50% or 60% of humanity along with the scientific technological advances that we are making. And that's where I would like to see most of the work being done.
And I agree with that. I'm going to pick a couple of themes that are not the data's missing or we don't have internet anywhere, because I think those have been brought up multiple times. Although it'd be interesting to end the conference on that note. Hey, we don't have enough data, therefore no AI. And it's interesting. I think we have enough data, and somebody brought that up earlier, and I know Barry has mentioned this a lot too. There is data. The question is who has the data, and can you get to the data, and how much does it cost you? So the three kind of themes I'm hearing, and I'm kind of going to attach to it. One is definitely education, AI and education. So, and actually, I'm going to pose these, and then I'm going to ask if anybody has Q&A around those topics, and then I'm going to come back to kind of how we're going to shape it. So education and AI and how those go together. The other one, and I know you've touched this a lot, evidence-based care, more protocol-based. I think those are very valid points. So how does that get incorporated? And then as far as usage of data goes, rather than just saying data, I think you brought up earlier outbreaks. Can we gather enough data to see outbreaks? And I would go one step further and say, if we can, is there something we do to detect certain things in those outbreaks, whether they're infections or whatnot, through image recognition? So those are kind of three common themes I see that we're kind of talking about, short of anything of data or governance or anything like that. So I don't know if you guys have any questions around that. I'd love to kind of get some questions, and then we'll kind of refine those a little bit, and then we'll go from there.
Yeah, can I just clarify one comment you made, which is, I don't think any of the panelists are saying that it's not useful or important to use the data that we have access to. It's just to say that a lot of the data that we do have access to may not be sufficient for certain contexts, culturally and otherwise. And really the solution to that is generalizing the training interface. So it doesn't have to be a smartphone. It can be a feature phone. It can be something that people all over the world have.
Yeah, definitely.
But I'd like to make a comment about the outbreak, is that, and AI can play a role, and maybe it will not, but the important part of that is to be able to do a evaluation, which is often speciation, and if there's a mutation to whatever is the cause or the source, you want to get to that before there's an epidemic, and the ability to evaluate that remotely, provided the establishment of the AI or some usability to monitor what is happening in the environment, that to me is a very important factor, because intercepting what is happening before the epidemic and before it ever becomes a pandemic is very, very critical. And it's doable. And the data on how to do that evaluation exists. It exists because it's being used. And there's a significant amount of data related to viral and bacterial inactivation, its repair cycles, its metabolic position after you think that you've inactivated it. Now, what I'm talking about is not treating humans. It's preventing humans from being infected.
I understand. There are definitely mutations of how a virus might change over time, or a bacteria. So we'll go to questions. We'll come back. Yes, sir.
So the thing is, there are two levels to me. I'm a physician. Someone from the mic?
Use the mic.
Mike, use the mic. And if you could state your name beforehand,
Yeah,
that'd be awesome.
Steve Diamond. I'm with
The other one.
Oops.
There you go.
Yeah, hi, Steve Diamond. I'm with the International Space Medicine Consortium. I'm a physician, and I think there are two levels that we have to look at in medicine. And one is a public health level, which I think has a really big bang for the buck, and where we sometimes in medicine, at least in the first world countries, we don't take that as much to heart as we do as medical care, where we focus on a person who's already sick. And the thing that brings both of those together, and it's one of the things that I notice in practice, is that the medical chart is fragmented, it's filled with junk, and that even though you have an electronic medical record, when I go see my physician, they're sitting there looking at their chart. So my feeling is that if we can create a greater granularity of history, and using the old Pareto principle, where 20% gets you 80%, I think with AI, we would be able to perhaps develop a platform of understanding at least the milieu that a person's living in through public health. Is there a propensity towards diabetes, for malnutrition, etc.? And then there's the second stage with AI looking at a particular chart, perhaps, and being able to bring in and aggregate the proper information from radiology, pathology, perhaps the clinical laboratory. I do have to say one thing. As an older physician, it used to be we had a history and we would make a diagnosis and then we would use the technology to prove that. I find that there's an overuse of technology as a pathologist where people just shotgun tremendous amounts of information. So to me, again, I think you have to be very careful in what information you're using, but I think the clinical chart, the history, is going to give you the biggest bang for the buck going forward.
Thank you. Questions, that's what I'm looking for. Yes. Go ahead.
I'm struck by
Do you want to turn on? Oh, sorry.
I'm struck by the fact that we talk about AI as an entity, and yet, in fact, in medicine, I will tell you, as a clinician, 80% of patients who walk into a doctor's office, you know what they have within 2 minutes and can take care of it. 20% of the time, you may have some problems where you really need to have people that are looking at it. I think if you want to go back, when I started 40 years ago, one of the most common diseases was treated with a surgical procedure. It was a peptic ulcer, which got a vagotomy and pyloroplasty, which we now know is a bacterial disease that is treated with an over-the-counter antibiotic. So the reality is there's an opportunity for AI to work in very specific areas to help us understand the complexity of why people get diabetes or why hypertension affects one group of people. But you know, I look at the third world and say, people are dying of malaria, they're dying of diarrheal diseases. You don't need to have AI to figure that out. You need to figure out how we get healthcare to people in the third world. I think we need to understand a lot of other things, but I think when we start to talk about AI, we need to talk about specifically what are we using it for? How is it being used? Is it being used in healthcare as a treatment option? Is it being used for understanding the etiology of the disease? Is it understanding the complexity of what drug-drug interaction occurs? And it's all done in the context, as somebody said, of it's in each individual person, depending upon their cultural background, where they are. There are a whole host of other entities or complexities. So I get somewhat frustrated when people use the term AI in healthcare and then sort of say, yeah, okay.
But that's how AI is used in every context. So here we're applying it to three things that I mentioned right before the questions, and I appreciate you guys giving feedback, and that's great. But we are looking. It's more questions. I don't know if you have a question at the end of that. Otherwise, we will. Everybody can come sit on the panel.
I guess the question is, should we be using it in the developed world right now, or should we be spending more of our time in the underdeveloped world?
I have one reaction and comment to those statements. So the reality is healthcare inequities, disparities, problems are multifactorial, and there are so many that are large scale. So there's 1 billion people on the planet, according to the WHO's data, who lack access to basic healthcare, where we need smarter and more enabled and equipped community health workers and other frontline workers who actually know what to do. We also know that in the developed world, medical error rates can approach 15 to 20%, depending on some of the data that you look at. And we know that it's way higher than that in the developing world. And then the third point that I'll make is that this has a real economic cost if we think about the SDGs. there's 100 million people who are put into poverty every year as a function of their healthcare costs. So they may be incurring costs which they don't necessarily need based on their cultural context, based on what is specifically wrong with them. And so I think your point is well taken that AI doesn't solve all problems, but that doesn't mean that it's not extremely useful for solving some of the most critical problems. Now, to your earlier point about electronic medical records and the value of the clinical chart, I 100% agree with you. I think the biggest problem with EMRs today is the data is unstructured, it's unverified, it doesn't capture the clinician's thought process. It actually is primarily used for billing and legal purposes as opposed to being used for clinical care. And it doesn't distill the signal from the noise. And so I think you're spot on in that a system needs to be created that better distills the signal from the noise.
We're gonna get into a can of worms if we open that discussion. I just know that discussion all too well. I want to focus more on kind of bringing it back to the proposals and just kind of going through that, because otherwise we will be here all night. We can grab drinks and sit if everybody wants. But we'll go two more questions, depending on the length, and we'll go from there.
There we go. Okay, perfect. Hi, I'm David Benram. I'm a psychiatry resident at McGill University working with a startup to predict the ideal, oh, there's feedback, and it's gone. Okay. To predict ideal treatments for patients with major depression. So the question I'm going to ask is, what about mental health? So a lot of what we've heard about today, and I've even gone to look on the Human Diagnosis Project website while we were talking, a lot of it is focused on diseases that are more traditionally, easier to diagnose and have more well-defined treatments, like a pneumonia or things like that. What are some of the projects that you've been working on, that you've been looking at with respect to mental health, with all the messiness that entails in terms of diagnosis and treatment, and et cetera, et cetera, et cetera?
We'll take one comment, and then we got to get to the proposals, and that'll be it. Yes, sorry, you had a...
So in relation to mental health, I can say that there are actually a lot more AI projects going on with very interesting results. So for example, somebody has found that over a period of years, if not over years, but over a period of time, using this information available from Skype talks, you can actually diagnose when a person is going through periods of depression or not. And actually also from Facebook data, I think they have developed an algorithm not only to be able to predict that somebody is going into depression, for example, but also a method to alert his peers to say, hey guys, you want to look after this person or something like that. So I think there's a lot more going on in the area of mental health than we know. I'm not a mental health expert, but I know a little more about it.
I know of a lot of projects going on in mental health, and one of the larger, and I'll comment on this, is very separate, with mental health is actually you can't record the data for many, many reasons, kind of like speaking to your lawyer, but there are a lot of projects around analyzing brain sequences and using light therapies. So there's actually a lot of not only research, but a lot of AI being applied there, because even as humans, we don't understand it. So that's where machines come in. I don't know if you have a comment towards that.
I just want to make a quick comment there, because we're at an early stage, but because of working, and forgive me if I keep bringing up space, or I'll call it remote or confined environments, sleep deprivation, depression, and not being willing to talk to your peers, because they're really not colleagues. I mean, everyone's different countries doing different work and competing with each other. And we have tested the potential of human persona robotics using AI, and being able to communicate, and a willingness and interest to do that, because it becomes very personal and confidential. We've also explored whether or not we can use that concept in remote areas.
So I'm sorry, I'm gonna have to. I'm cognitive time, so I don't want to keep repeating.
But that was a very excellent point that you brought up.
Sorry.
And I think it's really important to add that there's a lot around for mental health disorders in risk prediction and risk profiling and alerting. And it's wonderful if you can treat and prevent early. But there's also the risk of discrimination. Yeah, so alerting a peer group or even the person itself, you have a suicidal risk from Facebook. Yeah, so it might be about probabilities, but for the individual, the it could be very harmful and discriminatory.
I'm glad that's not
And
one of
we
the
have to think
proposals.
about these ethical issues as well. So
So-
this conference is about ethics, but there's unfortunately not one ethical speaker on the plenary sessions. So
I didn't know that. So let's we unfortunately we're running out of time because we got. Okay.
What about the aspect of keeping healthy people healthy for longer time? I mean, that's something we've not talked about today at all, and it's just a point that we need to have that too.
Yeah, I think I definitely.
Yeah,
Yeah,
we did mention that. Yeah, but go ahead.
I think
again,
that's
quick
that's
comment,
that's a fantastic statement. I think the way we look at it is that's absolutely crucial as well. But when we're kind of looking at the hierarchy of human needs, the people who are not well off and need to be helped are ones that we potentially are trying to more urgently serve than ones who are already well and keeping them well. I don't think that's. I think they're both incredibly important. I just think one is one that we generally tend to focus on.
real quick.
From the WHO perspective, I think that's a great idea because we do talk about promotion and prevention. And I think the reason we didn't talk about it is because there are relatively easy solutions, and many of them are being used. So, for example, apps that you see in all the smartphones are using the AI to help you get better and to keep track and everything. The only issue that I have in this is how does one regulate these AI technologies? We don't have a good answer for that. So where is the population getting its information from? And if all the health information, or a large amount of the health information it is getting is from these apps and from AI and from smartphones, then there needs to be some sort of, let's say, a rating system. This is rate 3, it's great, fantastic. Or this is WHO certified, or somebody else is certified. But I think the reason we didn't talk about it is because I think a lot exists already.
At some point, that I think we as humans also have to take some responsibility. Like if you're healthy, do the things that you need to keep healthy. But actually, I think it ties into one of the proposals, which is how do we apply AI to education, right? And not necessarily in keeping people healthy, but I think if we can elaborate a little bit on that, or some of our thoughts there, and then we'll kind of go through the others, and we will wrap it up at that point. So from an education perspective, and I know there's two folds of an education that we kind of brought up, one from a evidence-based perspective and teaching health.
my point is not mainly about
please.
education.
Yeah. No, go ahead.
But it's about learning healthcare systems. It's about evidence-based care and medicine, and learning about what is happening in real life.
Okay, so that from one perspective, would it be safer to say it's more about the workflows of what we're talking about, or?
And the outcome of care.
Okay, so more clinical evidence-based decision support. That's a better way. Okay, so more of AI for decision support, and then go ahead. Yes. No, elaborate on it, definitely. Go.
And institutional aspects of delivering healthcare at all. Patient-reported outcomes, citizen participation.
So how would you
in
see
shaping
AI
the
apply
healthcare
to
system.
that? So how do you see AI applying to that in your personal perspective? How would we use AI to enable that?
Mainly about integrating data and interpreting them and bringing them back to the system.
So using AI to interpret for clinical decision support, just to kind of put it in. Okay, awesome. And then from a other perspective, we talked about AIs teaching humans, which I think that's pretty interesting. So
Yeah. So the common meme that you probably heard is use humans to train AI to do certain things. So our view is, how can you use AI to train humans? And so what's interesting is the nature of our project is one in which essentially thousands of physicians are sharing training and teaching cases. But as they're sharing training and teaching cases, the system itself is getting smarter at helping both them as well as independently coming to answers or conclusions about given clinical cases. And so the idea that we kind of had in terms of the way that AI could make a tangible impact in the next 12 to 18 months and could actually impact potentially a large portion of the world is create a set of essentially 100, let's say, training cases that can essentially be used to educate community health workers on a set of cases to triage, diagnose, and treat the most common problems that have the highest clinical uncertainty that can be dealt with in basic healthcare settings. And what's exciting about that is that can then be used by anyone around the world to actually improve their skills. And then AI really plays two roles in that proposal. So one is actually helping evaluate what people have learned and how they have learned, as well as making recommendations to them with respect to what additional cases and additional information they need to take in the same way that you might get product recommendations from Amazon or content recommendations from Netflix. Imagine you could actually train through a personalized learning platform that essentially expands healthcare workforce capacity around the world. That's kind of what we think.
Well, I've seen VR teaching for autopsies, for surgery, and I think what you're saying is that AI could play a role in not just having the VR experience, but also whether it's verifying that what it was trying to relate or teach has really been known by the people, that it could be an evaluation phase of AI.
I think that's accurate. I think, for better or worse, AR, VR is still very far away for a large percentage of the world. And so what we're really trying to think about is solutions that could even work on a mobile phone that isn't internet connected. Really, that could be used to train people anywhere.
Got it. And let's take the last one. So we talked a lot about data and disease management, disease outbreak, infections. How could we apply AI to that? So one part we talked about is during the process being able to see if there's mutations, the disease that's going to come out of AI running a bunch of algorithms. But let's think it a little bit more higher level. How can we use AI in the form of detecting outbreaks or figuring out how to have if outbreaks are going to occur? Do you guys have any thoughts on how you would apply it?
Well, of course, looking at the causal effects of the that was what I talked about before, that you want to intercept and offset that. But how AI would be able to identify that an outbreak was imminent or that it had already incepted, that's a lot of the factors are involved. I mean, it could be the environment and where you're at, but it's if you want to do it before you're evaluating a patient, but you know that there are symptoms and it's getting started, that's perhaps a target for AI. But the point that I had made was just mainly to offset what the source was going to be.
I think we are very far from in the real world, because you could use it in the developed world, but in a lot of the places around the globe where you don't have internet connectivity, where you don't have the sort of electronic noise that helps you predict outbreaks faster. So for example, if you had information about the number of kids who are falling sick and therefore not attending school, if you had data about the number of workers calling in sick, or a whole lot of data like that, then you would be able to use AI to collect this sort of noise to predict that something's happening. The sort of the Google flu type of application. But in the real world, where we really need to predict outbreaks in Africa, in Asia, in other countries where there is a lot more outbreaks happening, and I don't think we are there yet, because we don't have the means to collect the information that AI feeds on. So if there isn't connectivity, there isn't electronic outputs, how do you do that?
So I think we're seeing more and more, and I know there's a few people who do this, using low-tech cell phones, quick Q&A questions. I'm just wondering, so again, here we're talking about AI interpreting data, right? So first the collection part of it, I totally agree with that. And then interpreting that data to see, is there commonalities, is there an outbreak, is there a common theme that's occurring that we're not catching? And I think we're seeing some things come up with that, especially using cell phones and just quick questions, right? Like, here's a text message, respond back, and yes, go ahead.
I just want to add one idea on AI that can be established very soon and very easily, because it's already done from everyone every day. That's the search engine. So if people have a symptom, or at least the prerequisite is that there is an access to internet. But if they have some symptom and they look after a disease or and they Google it, Dr. Google, you say, and then you get a hit list. And this hit list is driven commercially and not quality driven. If Google would implement a quality adjusted algorithm with a hit list, saying that at the first hit is a link to a site which is quality approved, which has a quality certificate that the information you find there is quality assured, then a lot of problems would be avoided by people going on in the first, clicking to the first hit, but that is linked to a blog where you're completely shocked after you've read what is your symptom about, or you go to a commercially driven site where you get recommendations which do not fit to your situation. So a quality-driven AI algorithm in search engines would be a dream.
But the eye of the beholder, you know, the person who's reading it and
Yeah.
going to do his own interpretation. I would like to just make one last comment to the audience, though, for future. We haven't really gone into certain technology protocols, like the use of biosensors, which we've been working with, related to wounds that's remote. And that can certainly be used to monitor and feed back thermal properties, depth, color, and do a diagnosis if, again, you had the internet or a smartphone and something that can communicate back. But AI is an important factor in that. And I think that could be very valuable going forward.
We'll do final comments.
So I think what you said is correct. I mean, already we can pull in data from the non-smartphones, the smartphones, handheld devices to collect surveillance data. I think if we can figure out a way of using data that's collected by researchers, because there's a lot of research going on in the rural areas, and I know that's private, confidential data, but if we can figure out how we can get, so there is a lot of data, I agree. But I think we can do much more, and we should do much more to collect data from.
And definitely a point we brought up is.
That's my point. So we could still use the data
Yeah.
that exists to make some predictions, but not.
And this is separate from the proposal, but I think it's a dual prong to something both of you guys have been saying, which is, one, we can use the data we have, let's apply AI to it, and combine the human element, and then at the same time, let's figure out a way to change the interface of which we're getting the input. And Jay, sorry, you wanted to add to that, I know.
Yeah. So I think the challenge with a lot of the solutions that are being proposed in AI, just generally at this conference, just because of the early days of the fact that it is AI, is there's really kind of two things that are being proposed. So one is kind of broad theoretical approaches, and the other are narrow practical approaches. For better or worse, if we want to actually succeed in using AI to help all of humankind, we're going to need broad practical approaches. Yep. And one of the reasons, oh, sorry.
I'm agreeing, sorry.
Oh, wonderful. So one of the reasons I think we're excited about the idea of using AI to expand healthcare workforce capacity, pointing out that there are 1 billion people who lack access to even basic care, is that we actually think that it is a way of making a meaningful dent on a problem that impacts a large percentage of the world, and actually in an interesting way hits several of the Sustainable Development Goals. So one, as we mentioned, was the first one of ending poverty. There's 100 million people who are put into poverty as a function of their healthcare costs. That's a World Health Organization number. The third is that the second SDG it hits is health and well-being. So as I mentioned, medical error rates, even in the developed world, and top institutions are 10 to 15%. Who knows what they could be in the developing world? I mean, it's almost scary to think how high they could be. The fourth, the third kind of goal that it hits is number 4, which is quality education and lifelong learning. Now anyone could really train, if we built such a system, to become a community health worker. The other one that it hits is number 5, which is gender equality. As you know, a large fraction of community health workers are female. There's also obviously a huge amount that knowledge and health understanding disparity plays in general in maternal and child health and everything else. And this is something that could help address that. And then the last one is decent work and economic growth. By essentially enabling people to train to be more competent to actually be able to deal with complex situations more simply, we could actually help solve that as well.
All right, with that, unless there's any final comments, I think we need to come to a close and make our way back to the main room. Thank you to all our panelists. Thank you guys for being here. We appreciate it, and we'll see you over in the other room.